All right, good afternoon, everyone, and welcome to the Primary Care Roadmap to Recovery, Part 2, COVID-19 testing. I am your host today, Ashley, and I will be assisting throughout the afternoon with this training. First, I just want to go over a few items and thank you all for attending this webinar. Our presenters have developed some great training content and we hope you enjoy it. Before we get started, I just wanted to go over a few things with you. First of all, this training is being recorded. On your screen, you should see a GoToWebinar control panel. I want to point out to you on the control panel some features. So the slide deck first can be found in the handout section where you download the document. And another feature on the control panel is the question and chat box. So this is where you will go in. If you have any questions throughout the training, please type them in the chat box. We have reserved time at the end of training for Q&A. There will also be a post survey included at the end of the webinar and then the follow-up email. So please take some time to fill out this survey as it is only 6 questions. The survey will really help us to understand if the content that's being delivered to you today is helpful. And we want to know what you would like to see in future trainings as it relates to the Maryland Primary Care Program and COVID-19. All right, also this training has been approved by MedShy for 1.5 credits that you can apply for if interested. After the training, you will receive a follow-up email with instructions and a link to apply for the credit. For non-physicians, you can apply also and receive an attendance certificate. You can check with your accrediting or credentialing organization to make sure they accept CMEs. Most organizations will accept CMEs to some extent or another. So moving forward, here we have our agenda for today's training. The first topic we will cover is the Maryland Safe Reopening COVID-19 Testing Overview. The second topic we will discuss today is the Roadmap to Recovery COVID-19 Testing Guide. That topic will then be followed by our 2 amazing guest presenters sharing their insights and experience on contact tracing in Maryland and COVID-19 and ambulatory care within their practices. That will then bring us to our Q&A forum, and we will end the training with closing remarks. Please note that throughout the training, we will also have 1 break. There's also another great feature that we will be using throughout this training in the GoToWebinar platform, and that feature is polling. So notice on this slide, we have added a test poll so that everyone can become familiar with this feature when the polls are presented throughout the training. The poll will appear on a slide like so, and then we will activate the poll, which will change the screen. Our first poll question is, what is your current role within your practice? And I will now start the poll so that you can answer. And on this screen, you can select your option by clicking on one of the radio options. And I will give about 30 seconds for anyone that wants to participate. All right, great. Thank you all for participating. I'm closing the poll now and publishing the results. So that is how polling works. Throughout our presentation, there are 2 more polls throughout this training. And as you can see, everyone has responded to the poll as 36% practitioners, care managers, administrators, office staff, and other. Thank you so much for participating in this poll. Okay, so moving forward, before we actually kick off the training, I would like to introduce you to our wonderful presenters. So again, starting with myself, I am your host, Ashley Johnson. I have over 12 years of experience in the healthcare industry, and I am an executive consultant in population health management with Medical Links. I also currently supervise a team of 12 community health workers, and our aim is to identify barriers to care within the community and eliminate social determinants of health. Some of my key areas of expertise include care management, behavioral health, addictions counseling, healthcare payer experience, and project management. I currently hold a bachelor's degree in psychology and am pursuing my master's in social work. I currently serve as an addictions counselor trainee for the state of Maryland, and I'm testing for my licensure as a certified supervised alcohol and drug counselor. Our first presenter of the day is Dr. Howard Haft. He has 27 years of clinical experience in primary internal medicine and 10 years of hospital-based emergency medicine, clinical, and leadership experience. He was founder, president, and medical director of Maryland Healthcare Associates, where he established a multi-specialty medical practice. Additionally, he was founder and president of the Maryland Foundation for Quality Healthcare, which provided healthcare education to uninsured and underinsured Marylanders. Dr. Haft served as Chief Medical Officer at Health Partners, a Waldorf-based charitable clinic serving Charles County and surrounding areas. In 2015, Dr. Haft was appointed as the Deputy Secretary of Public Health at the Maryland Department of Health. Currently, Dr. Haft serves as the Executive Director of the Maryland Primary Care Program, providing leadership and overseeing the day-to-day operations of the program. Our next presenter is Dr. Nkem Okeke. Dr. Okeke is a Kaizen-spirited healthcare executive with a combined 20-year clinical and administrative experience in primary care and patient-centered care redesign. In the last 10 years, she has led and supported several primary care transformation and population health initiatives, which focus on provider engagement, quality improvement, and payment reform. She served as the National Learning System faculty lead for Comprehensive Primary Program, CPC Plus at Booz Allen. She has also served as Special Projects Director for Population Health Initiatives for Priority Partners. And before that, she served as the Regional Telemedicine Coordinator at Kaiser Permanente prior to joining Johns Hopkins. She is the founder and Chief Executive Officer of Medical Links, a healthcare advisory and population health management firm here in Maryland. Her passion is to better integrate healthcare delivery systems. And those are all of our presenters for today's training. I will introduce our wonderful guest speakers during their segment of the presentation. So one last thing to mention about our wonderful presenters and guest speakers is that all presenters have no disclosures directly related to this presentation. So that concludes our opening remarks. So without further ado, I'm going to turn it over to Dr. Howard Haft to start the training. Take it away, Dr. Haft.
Thank you very much, Ashley, and thank you for the kind introduction. And I'm not so sure how wonderful I am, but I'm happy to do this presentation. And you can just go on, stop that picture and go on to the next slide, please. So we're going to show a picture here, a simulation, in just a moment. We're not going to quite start it just yet. But I wanted to just, before we dive into a lot of what we do in terms of testing and the implementation of testing, I wanted to just give you a little background about the why. We always like to start out with the why. Why do we do things that we do? And this simulation kind of gives me, and I hope you also, an idea about why testing and then subsequently contact tracing is going to be so important. So we'll just stop the video simulation right here, but you'll see at the top of this, there are three categories. They're recovered, healthy, and sick. We also talk about that in terms of also individuals who are susceptible, that's healthy, individuals who are infectious, that's sick, and individuals who are recovered. And recovered can be either recovered, I had it and I'm better now, which is good, because maybe you're immune, or recovered and sadly I died. So recovered could be either of those. Recovered, got over it, or recovered and died. And the important thing here is every epidemic, including this one, every pandemic starts off to the left of this screen. And if you recall at the beginning of the simulation, we saw a lot of people who were healthy or basically susceptible, and a few that were bouncing around in there that were sick or they were infectious. And there was a bar that kept those people who were, those few in there, together with the few that were susceptible or still healthy. And anytime a sick person or an infected person bumped up against one of those little dots that was healthy or susceptible, it turned them into a sick person. That's not what we want to have. That's how an epidemic spreads. And the way that we stop an epidemic is by creating that bar and identifying early on those individuals who are sick and limiting their exposure to those who are healthy or susceptible. The wider that bar gets opened, the more of those sick individuals are going to go out, and they're going to be able to touch individuals who are still healthy and susceptible. It doesn't matter so much if they touch people who are recovered, and certainly if they're dead, it has no impact at all. But if they're people that are touching people who recovered inside that little sphere there toward the left, nothing bad's going to happen. They've already recovered, presumably, and we know this for a fact with COVID, how long the immunity lasts, but presumably it lasts for a period of time, and they're not going to get it again. So that's really what this testing business is all about. We want to identify people, symptomatic or asymptomatic, who are sick, who are infectious, so that they don't touch people who are susceptible, so that they then don't touch other people who are susceptible. In order to do that, we have to create these barriers. And the only way we can do it is by testing and identifying those individuals who we know are infectious. If we just wait to see who gets sick, or who dies, we're way behind the curve. So that's what we're all about now. We're going out into the community and doing broad-based testing to everybody, not waiting for people to get sick, but testing those individuals so we can find those who are the asymptomatic individuals who might just bump up against a susceptible person. And that susceptible person might even be somebody's mother or aunt or grandmother or great aunt, who not only will get sick, but is likely to die from this. So that's what this is all about. That's why we test. On to the next slide. So under the governor's executive orders, we've gone through a series of iterations. So when we think about, we really came into the world of COVID this year, and in Maryland, really March or so, maybe late February, and we're only in July now. So it's been half a year at best. Think about all of the trials, tribulations, permutations, variety of different orders and directions and policy and changes and to test, not to test, how we test, who we should test, who we shouldn't test in that short period of time. Absolutely unprecedented. But let me summarize it here where we are now. For testing now under the current governor's executive orders, which is the law of the land in Maryland, healthcare providers shall order a COVID-19 test for any individual who believes it's necessary, regardless of their symptoms. So we've gotten all the way from the asymptomatic stuff. Healthcare providers shall collect COVID test specimens in a manner that's in accordance with the U.S. Center for Disease Control, which means that we need to do it appropriately and using the appropriate precautions and PPE. And we're going to talk all about the hows and what's to do later in this presentation. And then all healthcare providers and facilities that offer community COVID-19 testing shall make the testing available to people, to any person presenting to a test site without regard to their ability to pay, type of health insurance, participation in any provider network, which means there's no barriers to patients to saying, I want to get tested. They shouldn't worry about whether they have to pay a copay, or if they're uninsured, that they're not going to be covered by the CARES Act. Everybody, there's no personal responsibility, financial responsibility. So we've unleashed the barriers, said anybody can be tested on demand, basically, or should be tested, should be done appropriately and safely. And for patients, don't worry about the cost, that's covered. We care about your health and the health of the country right now. But we also said that anybody doing a test in any lab, or as we do more testing, the testing itself, in point of care, which is something that we'll talk about later, then as that happens, we want to make sure that we report those tests to the state so that they can report it to contact tracers, so appropriate contact tracing can be done. So we're going to continue to go through evolutions in testing. So where we are now is not where we're going to wind up. Where we were with nasopharyngeal tests is not where we are now with nasal tests, which are much easier, safer, easier to do. Where we are now with doing those tests and the PCR tests is not where we're going to wind up in a few months with the advent of other easier tests to do and other tests that don't have an associated delay in reporting that we see now that's extant throughout the system because of the extraordinary demand. So we'll move more to point of care testing like we do typically during flu season, or for pediatricians with RSV and others. So we're going to continue to evolve. This is just a moment in time, but we thought it was really important to give you this information at this moment in time to know what the state of the art is now and what you're expected and what you can do, and make it as easy as possible. Knowing that next week or 2 weeks from now, there'll be some additional enhancements. It'll make it even easier and better. And we need to get all this in line before the inevitable flu season comes. In the fall, things will again look dark, cold, perhaps a little more grim, and we need to be prepared for that. We absolutely need to be prepared. Next slide. So here's where we are currently in the state, and it's we could say we're better in Maryland than others, but can we say that we're good? You know, I recall sitting with my colleagues in the department and the secretary in March and saying, geez, we really hope that this doesn't really produce the kinds of negative effects that we think that by October we'll see 5,000 deaths in Maryland. That was just unthinkable at the time. Well, here we are in July and we have 3,272 deaths. That was unthinkable at that time too. We've kind of become jaded, comfortable with the fact that we're continuing to see people die and that we have 80,000 almost cases in the state. This is really an overwhelming pandemic and it's affecting us in so many ways. We're seeing now, because we're doing more testing, we're seeing more cases, and it's just representative of the fact that there's a lot of cases, a lot of asymptomatic individuals out there. When we test 70,000, and we test 20,000 people in a day, and 5% of them are symptomatic, or I'm sorry, are mostly asymptomatic, and 5% of them are positive. It means when you think about that across the state, how many people are walking around right now who are asymptomatic positives who might be bumping into susceptible people. It really is a very, very significant amount of individuals. So we have done a lot. We still have a lot to do. Next slide. So just to sum it up, and then we'll get into the meat of this presentation. Why do we test for COVID-19? We need to know who are the asymptomatic carriers. That's the number one. That's why we're testing everybody, all comers. And so that they will not unknowingly infect others. No one asymptomatic person wants to make their aunt or uncle, your aunt or uncle or grandmother or grandfather sick or die because they didn't get a test. We also want to know who the pre-symptomatic carriers are, those who are going to get sick, they just don't know it yet, so that they won't all infect other individuals. We also want to test people who have been traveling recently. We know we're in relatively good shape compared to a lot of the Sun Belt states and others. And if people have traveled there, we want to know before they go back into the community, particularly, have you picked up something that you don't want to bring to our friends and neighbors here? And you want to know if they're not infected after any kind of exposure. Many people want to know if their employees are infected before they come to work. So they should be testing before they come to work. We know that's particularly true for skilled nursing facilities. And many people just want to know, and I'm sure you've seen many of them, just for their own peace of mind. Do I have COVID? I had a little cough, I had a sneeze. I know you could be asymptomatic or symptomatic, but I just need to know because I need to know how to protect my family and my friends. And this is the only way we can stop the spread of the virus. And it's the only and most important way, as Dr. Feldman will tell you at the end, to link to contact tracers to keep these individuals from allowing those that they already came in contact with contacting others. So all of that fits together, and that's why testing is really important, and why, even though we're not at a final stage now, why it's important to get this information out to all of you. So thank you. I'll turn it over to next slide, please. My good colleague and friend, Dr. Okeke.
Thank you, Dr. Haft, and thank you for a great introduction to our discussion today and really highlighting the reasons why we should promote testing for COVID-19, because we ultimately want to curb this this pandemic. So good evening to the attendees, and thank you for being here. In this session of the presentation, I'll discuss some guidelines on office-based COVID-19 testing and how you can get that set up in your practice. You should have by now downloaded the guide on the COVID-19 testing, which you can review in detail after this webinar. Next slide. All right, so since testing is occurring widely, and this is really one of the key public health activities that we need to keep doing to reduce the spread of the coronavirus. As Dr. Haft has already shared, the governor and the Secretary of Health are trying to encourage us to test as many people as possible. So our objective here is to see how we can support you in putting together your own COVID-19 testing strategy. And it's either you do this in your practice, or you can continue to place orders and do it and send folks out externally as well. All right, who can be tested? This has evolved over time, but right now we know anyone can be tested. So as of July 1st, the guidance on testing is that anyone can be tested, and this will include patients that demand this. This will also include patients who are at risk. This will also include patients that you deem high risk based on some clinical criteria as well. All right, so when you are, even though anyone can get tested, just keep in mind patients that you need to prioritize. You want to prioritize your symptomatic patients, as well as asymptomatic or pre-symptomatic patients, but mainly those who have had contacts with individuals that are confirmed to be COVID positive, residents and staff of congregate living like nursing homes, assisted living, health workers, and first responders, high-risk unstable patients whose care could be altered by diagnosis of COVID-19, individuals in close contact settings, such as manufacturing plants, schools, and so on and so forth. And lastly, also individuals who are coming in from out of state or who recently returned to Maryland. Another group of patients that you could consider as well are those who are high risk as identified by the COVID-19 Vulnerability Index. I'll discuss more about the CVI in the next 2 slides. So for those of you who are in the MDPCP program, I'm sure you are familiar with this CRISP MDPCP report. So if you are able to reach the pre-AH tool, this is a tool that determines the likelihood of avoidable hospital events. And let me see if the pointer works here. There you go. So you can access that either using either one of these 2 links. And when you do so, it'll take you to this page where you can see here the COVID vulnerability index here. So if you use the results that you get when you look at this for your own practice, try and target patients who have a risk score of 3, which we consider to be moderate risk, to a risk score of about 5, which indicates severe risk, and prioritize how you can outreach these patients. Again, don't scare them and say, well, I think you should be tested. We suspect that you might be in danger, but at least encourage them to come in and get tested as a preventive measure. So let's take a quick poll at this juncture just to see how many of the MDPCP practices who are attendees who actually use the COVID-19 Vulnerability Index. So as Ashley gets the poll activated, please select one of these options. If you use this CVI index most times, sometimes rarely, or you're yet to start.
And we'll be closing the poll in about 5 seconds. So if everyone can please choose your response.
Great. So you can see that 25% of us use it most times, 22% use it sometimes, 4% rarely, 49% not started. Now, for those of you who use it sometimes, most times, thank you. Keep up the good work. A lot of effort went into this, so it's great that we are able to leverage our resources to help reach our patients that are high risk. And for those of you who are yet to start, again, reach out to your CTO or your practice coach to help you have a way that you fold this into your day-to-day workflow of just reaching out to patients and doing your care coordination and care management for your patients. And as Dr. Haft had previously mentioned, based on your clinical assessment, patients who are older, patients who are immunocompromised should be folks also that you target for COVID testing. And you can use your practice EMR data to identify subpopulations as well of high-risk patients for severe COVID-19 complications, such as your patients with diabetes. Now, Dr. Haft had highlighted probably about 10 or so reasons why this is important, but I just want to call your attention to two of them. The benefits of office-based testing. The first is that it is likely that you would get this done for your patient in a timely fashion, and the patients can test immediately on site when you need them to, and it's guaranteed that the testing occurs without delay. You also can track the patient's status following the test and be notified in a more timely manner. To get started, things you should think about is your testing location, the COVID-19 specimen collection options, testing in a safe way and best ways to handle samples, choosing a lab, and of course, how you can be reimbursed for swab collection. So testing location. Make sure you choose a site that is well ventilated, make sure that the area is separated, and only allows for the minimum number of staff required at that particular time. We would recommend a few testing locations like drive-by, lot tent, or a dedicated exam room. After you've selected your testing location, the next thing to consider is your collection option. This will be based on your accessibility to testing materials as well as the ease of collection. The 5 options, as you can see here: nasopharyngeal, oropharyngeal, nasal mead turbinate swab, nasal swab of your anterior nares, and nasopharyngeal wash or aspirate. While all these options are acceptable, TDC recommends collecting the nasopharyngeal swabs. All swabs should be placed immediately in a sterile transport tube to be sent to the lab. Next, you have to ensure that you have a plan for safety. Healthcare providers are likely to come in contact with patients who may have the COVID-19. So you should take necessary precautions, as most of you currently do. Although it is recommended for you to wear a form of face mask at all times, healthcare professionals in the room with the patients that are being tested have to wear PPE. This includes your N95 face mask, face shields, gloves, and gowns. To learn more about the CDC guidelines, you can visit this link here for more details, and this is also in the guide that you downloaded. Okay. So with your PPE supply, try to make sure that you, first of all, assess your burn rate. So you know how many mask, gloves, face shields, and other supplies that you need. And you can establish a purchase schedule to reorder supplies as needed. For a list of PPE suppliers and vendors, you can use this link here to see what the lists are and your opportunities there. But you can also fill the request form and submit that to your local health department. Also, remember that you should consider the ways that you can ensure you have enough testing kits and proper labeling forms to submit your test samples. And you can also reference the guide. They have more information on how you can secure PPE supplies. The fourth is how you should choose a lab that can get you the fastest possible reporting. So it is advised that you look at the list here. If you visit this, you see a list of labs in Maryland, and this includes both commercial and state labs. Another thing that could be helpful is to be very aware of the turnaround time when you do send in labs, especially if you want quick results to get your patient to the right intervention and care that's needed. Here is a snapshot of a report. You can have access to this report on CRISP. And this here actually shows you the percent of COVID-19 test results reporting in under 2 days by the laboratories. This is current as of July 4th, and this can be accessed again in the CRISP Public Health Dashboard. Not much has changed since July the 4th, but things do change pretty quickly. So it's good for you to stay up to date to make informed decisions. You can see more details when you hover over a particular tab. For example, if you're looking at Quest, about 30% of tests are reported within 2 days. The average reporting time currently is about 7 days. However, if you look up here in the chart, you can see other labs that have a faster turnaround time, and this includes St. Agnes, MedStar, and Johns Hopkins. So keep refreshing this report and looking at it to see which labs that you can partner with to get your result in more quickly. Next, you need to know about reimbursement. And so laboratories that are processing COVID-19 testing for Maryland residents must accept reimbursement from patients regardless of their insurance types. So patients should be tested for COVID-19 even if they are uninsured as well. Providers and laboratories can still be reimbursed for that. The CARES Act also includes a limited provision that waives patients' copays for testing. So I'm sure if your patients know about this, this would also encourage them to come forward and test. The American Medical Association also summarizes here the reimbursement codes for specimen collection. Please remember that if a provider actually has an E&M visit with a patient, that you cannot bill separately for swab collection. But if this is occurring outside the E&M visit, then you can bill for 99211 or 99000. Okay, here's a list of reimbursement codes by payers. And for the most part, they're generally similar. But I want to draw your attention for uninsured patients, you can actually apply for reimbursement. If you visit this link, it will take you to HHS HRSA COVID-19 uninsured program portal. You can enroll as a provider here, verify that the patient is uninsured, submit the patient information, and then you can set up a direct deposit with opt-in pay. If for any reason your practice is not able to test in the office, you can also refer them to nearby sites. If you click on this link, you see a list of testing sites that are currently active and up to date. So know them, be familiar with them, so you can refer patients to sites, nearby sites that's more convenient for you and for them. So finally, also note that results can be viewed in your patient's records and through the CRISP ENS report prompts. If a COVID-19 test is performed on-site and specimens are sent directly to a lab for analysis, results should appear in your EMR through the existing interfaces you already have with your lab systems. As we mentioned earlier, there's been a slowdown in reporting results for some labs due to increased demands, but you can keep up to date with this information. So again, you can decide what best testing strategies you can continue to maintain as things evolve. Okay, so we'll end this session with another poll. Again, if you can select which option applies to you, where are you with testing for COVID-19 at your practice? Have you started, not started, do not intend to start, or you will consider starting?
And we will be closing the poll in about 5 seconds.
Wow, this is good results. So about 35% of practices attending this call have started. That is reassuring. 9% have not started, 20% do not intend to start, and 35% will consider it. So for those of you who started, that's great and reassuring, as I said. And for those of you who haven't, we encourage you to keep considering what it is you need to get started. Please reach out to your resources, your CTO, your practice coaches to advise on best ways that you can get started. But again, regardless of what decision you make, our goal is that you are safe and you stay safe as well as your staff. So we hope we're in this together. We can keep encouraging you to do what you do on a daily basis. We were just going to go to a quick 5-minute break, and then we will come back and hear from our guest speakers on contact tracing and changes in ambulatory care with COVID-19. I'll be here along with the other speakers at the end of the presentation for the Q&A session. So back to you, Ashley.
Thank you so much, Dr. Haft and Dr. Okeke. As Dr. Okeke has stated, we will now have a 5-minute break. After we return, we will continue to our wonderful guest speakers. And thank you so much for joining us today. The break will begin now, and we will come back in 5 minutes. Thank you so much. All right, and thank you for coming back. That is going to conclude our 5-minute break. I would like to start off by introducing our first guest speaker. That is going to be Dr. Katherine Feldman. Dr. Feldman is a public health leader with over 20 years of experience leading infectious disease research, surveillance, investigation, and responses. Dr. Feldman currently serves as the Chief Public Health Scientist at the Department of Health and has experience spanning state and federal public health agencies. With a Master of Public Health degree focused on epidemiology and her DVM degree, Dr. Feldman joins us today with much insight and experience as it relates to contact tracing within the state of Maryland. Dr. Feldman, take it away.
Thank you so much, and thank you for the opportunity to be here. One thing I don't know is, do I advance the slides or do you?
I will advance for you.
Fabulous, thank you. Okay, well, without further ado, we'll move on to the next slide. So just to ensure that everybody's level set, and I'm fairly certain that this audience is already well aware of what contact tracing is. Contact tracing involves identifying people who have an infectious disease, the cases, perhaps your patients, and the people with whom they came in contact, the contacts. And to prevent further spread of disease, cases are asked to isolate at home, and then the contacts are asked to stay at home and monitor themselves for signs and symptoms of COVID-19. And in this manner, the transmission cycle is interrupted, and hopefully there will be fewer additional cases as a result of this individual and their cases. Next slide, please. So contact tracing is a tried and true tool used by public health for decades. It's not new. It's certainly new to the public health when we do our job well. People don't know we're out there doing it, and they don't know that the diseases are a concern. And so part of our challenge with contact tracing is educating the public about what it is and reassuring them that this is real, just basic public health tools that will stop transmission in its tracks if used effectively. It's used all the time to respond to sexually transmitted infections. And of course, people don't like to talk about sexually transmitted infections. So another reason why people might be unaware of contact tracing. But it's certainly used for many other diseases, even recent diseases like Ebola in Africa. It was absolutely critical in stopping the Ebola outbreak in Africa. And then here in the US, when we were concerned about the possible introduction of Ebola, we used contact tracing when cases were identified or brought into the US. And so this is a critical step in decreasing the number of COVID-19 cases. And so you hear a lot about it in the news, and I'm delighted to be here today to tell you how we're approaching it in Maryland. Next slide, please. So what it involves is just a lot of hard work, a lot of boots on the ground, hard work of interviewing people with COVID-19 and going through a timeline with them to identify anyone they had close contact with during the time they may have been infectious. And we define that infectious period as 2 days before the onset of symptoms until the interview. And close contact is defined as being indoors within 6 feet for at least 15 minutes, regardless of wearing a face covering. The contacts then are all called, and I've skipped an incredibly laborious step in this process, which is getting contact information for the contacts. You might not be surprised that when we interview cases, they might say, yeah, my friend Tim Jones was over, I don't have his number on me, and so you often will get very incomplete information. So there's an awful lot of detective work that goes into finding contact information for the contacts that are named. And that's why so much attention is being given to making sure that when lab tests are ordered, all of the demographic information associated with those lab tests and the patients are completed. And that's really critical to help us with our contact tracing efforts. So we call the contacts to notify them of their potential exposure. We keep the name of the case confidential. So when we call, we say, we understand you've been exposed to a case of COVID-19, but we never reveal who the case was. Now, obviously, there's a lot of household transmission, and so in the case of household contacts, they're well aware of who the case is. But we're very mindful of protecting confidentiality. When we talk to those contacts, we refer them to testing. And later in the slide deck, I noticed an update that needed to be made where I say only symptomatic cases or contacts, excuse me, are referred to testing. But really, it is all of the contacts. We're really creating a push now to test contacts regardless of whether they have symptoms or not. And so as Dr. Haft was very nicely alluding to, the rapidity with which guidance has changed and things have changed. Initially, really, we're focused on the symptomatic contacts and getting them tested, but now we want to get everybody tested. So all of the contacts. When we talk to them, we educate them about the signs and symptoms to look out for COVID-19. and we advise them to quarantine for a 14-day period from their last exposure. And so as part of that quarantine, we help connect them with services to make sure that they can get through that quarantine. Next slide, please. So in Maryland, we have 24 local health departments, and there are contact tracing personnel in all of the local health departments. We also have contracted with the National Opinion Research Center at the University of Chicago, and they provide support for contact tracing as well. And so the contact tracing is done, these interviews are done by a combination of personnel in the local health departments, as well as contact tracers with NORC at the University of Chicago. All of those NORC interviewers, however, from Maryland are Maryland residents. So when we set up the contract, we really wanted to ensure that we had local capabilities being developed, and so that these folks might, in the long term, support our local health departments more directly. We have around 1,350 contact tracers who conduct these interviews, and cases are asked about their current health. We ask them about their whereabouts during the incubation period. This is our case investigation piece, and it really provides clues into where they might have been exposed and allows us to try to put out fires and investigate if it looks like an outbreak. This case might be associated with an outbreak. And then we ask for the infectious period. We ask their whereabouts and everyone with whom they had close contact. Sometimes this is just a couple people, sometimes it's quite an extensive list. Contacts are asked about their health and their whereabouts. And for both cases and contacts, guidance is provided for isolation or quarantine, isolation for the cases and quarantine for the contacts, and ensuring access to resources, whether that be a single parent who might not know how to manage isolation and childcare, or groceries, mental health services. This guidance is typically provided through the local health department. So that's an example of when somebody with NORC might start an interview if more specific guidance for some of these situations is needed, then the local health department would step in and fill in the gaps, because the local health departments are so critically attuned to their communities and the available resources in those communities. Next slide, please. So COVID Link is Maryland's contact tracing platform. This is a screenshot of our website, so there's information that you can review on our website. We're actually building out a new website, so there should be even additional information. But you can certainly direct your patients to the Maryland Department of Health website to learn about our initiative. And you'll see at the bottom of the screenshot, respond, answer the call, and stop the spread. And that's our communications initiative to really get the word out there that it's going to take all of us. It's going to take the contacts answering the call when the Maryland Department of Health contact tracing team calls to really stop the spread of COVID-19. Next slide, please. So during isolation for the cases and quarantine for the contacts, individuals are monitored by text, a secure web survey, or by telephone. And so individuals get to set this up in their initial interviews. Contacts, here's the bit that needs updating. Contacts are referred for testing if symptoms develop. Actually, we're really starting this push to test all contacts, whether they have symptoms or asymptomatic. These are the folks who have been clearly defined as having exposure. And so this is a pool where we think it's likely we'll see positives, and it would be important to identify them in order to stop transmission. This slide also has another update that's needed. Cases are released from isolation when they meet recovery definition, that is 10 days, at least 10 days since symptom onset. And just late last week, before I had a chance to realize it, CDC updated the recovery definition to include just at least 1 day has passed since resolution of fever without the use of fever reducing meds, as well as improvement in COVID-19 symptoms. So the two updates to the slide: all contacts should be referred for testing, and then recovery definition is at least 10 days since symptom onset, and at least 1 day has passed since resolution of fever without the use of fever-reducing medications. Next slide, please. So this diagram just is kind of a high-level overview. I don't expect anyone to read it, of the automated communications that happen for a person in isolation or quarantine through our contact tracing initiative. So an individual would have the initial interview by phone. After that interview is complete, and the individual is selected whether to receive follow-up messaging via text or email. Then they'll get those welcome text or email, and then the follow-up, which is every 3 days for folks in isolation and every day for a contact in quarantine, can be done either by phone, text, or email. And then at the end of the isolation or quarantine period, they'll get a release from isolation or quarantine text or email. And if you move on to the next slide, I'll just show you some examples of these messages. So this is on the left is a text message, a welcome text message, and on the right is an email welcome message, just letting the folks know they've been enrolled in the system and providing some additional resources. Next slide, please. This is an example of isolation information that is conveyed to our cases, explaining how critical it is for the case to isolate and to make sure they understand what that means, as well as providing some other links to information. Next slide, please. Yep. Our folks who have been directed to self-isolate or self-quarantine are also provided a work excuse letter that they can access. It's a letter generated specifically for them that is dated and can be authenticated by an employer. And so all of this is automated through our system. Next slide, please. And then finally, yay, Mike has gotten through his isolation and is being released. And so this is the end of monitoring information. The isolation period is over. Next slide, please. So I want to just finish up with a little bit about communications, as well as some of the metrics that we've recently started sharing publicly. So again, we are up against a huge challenge of getting folks to answer the phone and willingly participate in contact tracing. And some of it is just educating them as to what that involves. And some of that is just to change the culture. You know, I was told by one parent that any kid under 25 isn't going to answer the phone. You have to text them. So as we get feedback like that, we're always working to refine our processes. As with all things COVID, this was rolled out rapidly. And we are learning a lot and adjusting to make sure we can optimize our response rate. This is a screenshot of a video. We have a number of different PSAs out there, testimonials from real COVID-19 recoverees who talk about their experience and why it is so important to participate in contact tracing. And so you can help educate your patients that if they or their contacts get a call with a caller ID of MD COVID, Maryland COVID, or this phone number 240-466-4488, to please answer and to please cooperate with the contact tracing efforts. And I would definitely urge you to navigate. I put some links at the end of my slides to go hear about Claudia's experience and several other individuals who describe how important it is to participate. Next slide, please. And so last week was the first week we put forth public-facing metrics. We went live with our system early June. We allowed several days for data to kind of reach some sort of steady state. So we started our measurements on June 15th, and we put these out last Wednesday. So we'll update these tomorrow, next Wednesday. And so you can expect at this point weekly updates to our public-facing metrics. We also anticipate that we'll add to them. You know, again, everything is just really getting launched and underway. This is timeliness. So what proportion of our cases had their outreach within 24 hours of the case being entered into our system. And of course, time is of the essence. And so we're very concerned as we see these lab turnaround times creeping up, that we are not getting to these cases quickly enough. So we work really hard to do our first outreach within 24 hours of the case being entered into our system. You can see we're in the ballpark of 80% on most days. That really low bar is the 4th of July. But we are certainly striving to meet at least an 80% threshold of getting the first outreach to cases within 24 hours. Next slide, please. These are the two other graphs we're publishing currently. Again, we anticipate we'll be publishing more, but the left bar graph shows completeness of reaching cases. So it takes you from the total number of cases entered into COVID link, which for this time period was almost 10,000, all the way to the cases that had a phone number. I already mentioned how important the contact information is. So the number of cases with a phone number, the number of cases who were successfully reached, the cases who had a completed interview, and then the cases who provided at least one contact. And so you can see the numbers fall off for a whole lot of reasons. And so we're really working hard to optimize the processes and get a higher completeness number. On the right, how many of the contacts were actually reached. So it's a similar progression. On the left, the leftmost bar are the total number of contacts entered into COVID link for that period, and all the way on the right are the contacts with a completed interview. So again, there are any number of reasons why folks might fall off as you go down this, but we are working hard to get these numbers up. Next slide, please. So really, just to wrap this up, how can you help? Really educating your patients that they can take action to interrupt transmission is huge. And so if you have a patient for whom you suspect COVID-19, please advise them to isolate, lay low, don't go out until the test results are known. And then you can tell them that if they test positive, they should expect a call from one of our contact tracers. It might be a NORC interviewer, it might be the local health department team, to provide further guidance on isolation, collect the information regarding their whereabouts in the 2 weeks before illness onset through present, as well as to collect the contact information for the close contacts during their infectious period. And again, you can really encourage them to answer the call. Look for MD COVID on their caller ID or 240-466-4488. And the final thing that didn't make it to the slide, but is also critically important, is providing this complete demographics when completing the lab requisitions. So really address, phone number, all the other things that are so critical for us to be able to respond effectively and stop the transmission of COVID-19. Next slide. I think I just did another screenshot of some more. Oh, here's some resources. Let you peruse those. And you can pass these along as they might be helpful to your patient and your practice. And the final slide, I think, is just another screenshot showing you some of the vignettes that are posted on our website that might be useful to help with patient education. And I think that's it. Thank you so much.
Thank you so much, Dr. Feldman. You provided some wonderful insight into contact tracing in Maryland. And we want to just thank you for these wonderful slides that you shared with us today.
You are most welcome.
So moving on, our next guest speaker is Dr. Stephen D. Sisson. Dr. Sisson is a professor of medicine at the Johns Hopkins University School of Medicine. And his area of clinical expertise, is internal medicine. He currently serves as Vice President of Clinical Operations for the Office of Johns Hopkins Physician and as Director of the Johns Hopkins Physician Education and Assessment Center. He is the Philip A. Tumulty Professor of Medicine. Dr. Sisson holds a BS in chemistry from Duke University. He earned his MD, Alpha Omega Alpha, with research honors at Tufts University School of Medicine. He completed an internal medicine internship and residency at Johns Hopkins, serving as Assistant Chief of Service for the Barker firm, and he joined the Johns Hopkins faculty in 1996. He has served for 15 years as the Associate Director of the Osler Medical House Staff Training Program and is active in the American College of Physicians, having served as governor of its Maryland chapter and where he currently serves on the Board of Regents. His research interests include community outreach, medical education, and ambulatory care. Dr. Sisson, please take it away.
Thank you very much. Can you hear me all right?
Yes, we can hear you.
Wonderful. I think people can figure out my age from that data that you gave, but we'll talk about that later. Let's go to the next slide. All right. My role, the Office of Johns Hopkins Physicians, is sort of the umbrella oversight of, we do a lot, but one of the things that we do focus on is our ambulatory care sites. And we had over 4 million ambulatory visits last year. So it's a big enterprise. And this includes the ambulatory areas of Johns Hopkins Hospital, as well as Bayview and Howard County and Sibley and Suburban, and then Johns Hopkins Community Physicians and Johns Hopkins Regional Physicians. So big organization. And we are paying close attention, obviously, to things that are coming from the state on what we can and cannot be doing regarding COVID, and we want to excel in this area. So obviously, we think that COVID will remain a health threat until one of three things happens, or all of three things. We get herd immunity. And if you read the articles about the duration of antibody response, that's a little disappointing. A vaccine or a highly effective treatment becomes available. And so we obviously feel this is not going to be happening in the very short term, but remain optimistic for the medium and long term. We do think that health systems must adapt ambulatory workflows to adjust to varying levels of pandemic activity, and we call them simmer and surge. Right now we are at simmer, and the question is, when will the next surge be? Before we go to the next slide, the context of what I'm going to explain is what we did, what we've learned, and what we have done in response to Governor Hogan and Bobby Neal's recommendations are on reopening clinics. And that is where we launched our own internal process to figure out how to safely reopen our ambulatory care areas for both simmer and surge. And that is what we're going to talk with you and the lessons that we learned. So if we can go to the next slide. So one of the things we did was we actually broke up clinical care into what we call degrees of open. When the pandemic first started, and I think most of us had the same experience, things really shut down nearly completely, and in some areas, essentially completely. Then what happened, even before there was any reopening, we noticed that clinicians started opening up a little bit at a time. And what they were doing was they were moving through their own degrees of open. So when we nearly completely shut down, we really were providing emergency care and not much more than that. And very soon after that, we saw that our providers were starting to add in ways to provide urgent and acute care. I'm not going to talk about telemedicine in this right now, but we all know that telemedicine started to help us with all of these gaps, but we also continue to have in-person care. We then also got into a growth as people who really needed to follow up were being followed up. So these are the people, a patient I might see who I changed their antihypertensive or their diabetes medication, or I put them on an antibiotic, and we really needed to see if those individuals are doing better. And that's basically where we stopped. So we started treating emergency, urgent, and follow-up care, but we were not necessarily doing routine preventive or elective care. And we were waiting to see which way the pandemic was going and which way the governor and the state wanted us to go. But we did actually, with our clinical departments, had these discussions to prepare for what we would look like in the future. And we think these degrees of open are going to continue to flex or wax and wane as we move between simmer and surge. So our next step will take us to the next slide. So then we deconstructed ambulatory care into something very, very schematic, but 3 distinct areas of ambulatory care. And we did a deep dive in each of these 3 areas. So the first was scheduling the original encounter. And how do you make that decision of whether it's in person or telemedicine? And we think that that is actually where degrees of open will continue to play during simmer and surge. So as we get back into surge, we think that more of our care is going to shift to telemedicine, whereas while we're in simmer, that gives us more of an opportunity for in-person care. There will always be patients that we will need to see in person. And there will be many patients that we can manage just as well through telemedicine. But there is a big gray zone where those patients you might get by through a telemedicine encounter because it's just not safe. And that would be as we're moving into a surge environment. Whereas during simmer, you might actually move those patients into in-person encounters. So that's where that degrees of open really was discussed in detail. And each clinical department actually worked on that for themselves, and they figured out who were the absolute must-see in persons, no matter what the environment was, and who was the these are really just fine as telemedicine all the time, and then that gray zone in between. So after that comes area 2, and that is where we were very much in agreement with the state about the fact that practices must do everything that they can to distinguish and separate those patients who are COVID negative and non-PUIs from PUIs or patients under investigation and COVID positive patients. And we developed a full quiver of arrows to do this. So we worked very hard to leverage every opportunity to figure out, is this a COVID positive patient? Is this a definite COVID negative patient? Or is this a PUI? And that actually goes back to step 1, where when somebody calls for an appointment, to get an appointment, we actually use step 2 and go backwards to step 1 and say, you know, should this be a telemedicine encounter, and or is in-person okay? And if that patient is COVID positive or PUI, that is going to tip the hand in favor of a telemedicine encounter rather than an in-person encounter. COVID negative patients who are non-PUIs can go either way, and some of that again depends on simmer and surge. So how did we do that? How did we help differentiate those patients? Well, number 1, we had routine outreach. We leveraged our EMR, we use Epic, to reach out to patients and urge them to contact us and their providers if they have any symptoms of COVID, particularly if they have an upcoming clinical encounter, upcoming visit. And so that is part of our routine messaging. It's on our website. It's in my chart. It goes out as regular messages to patients. But we also do timed outreach. If a patient has an appointment coming up within 48 hours, we begin to leverage other opportunities to reach out to them. So we send a MyChart message. So we, again, using the EMR, we reach out to them and provide them the screen for symptoms. Many of our practices, when they call to confirm visits, they will screen the patients at that opportunity. If our patients use electronic check-in or pre-registration, which is available in Epic, we use that opportunity to do the screen again. If the patient comes into our building entrance, we do building entrance screenings, which I know you all do. We also have in-car workflows. So some of our practices, radiology in particular, will ask the patient to contact the clinic from their car, and they will do a screen. And if they pass the screen, and if their waiting area is ready to accommodate that patient, they will have the patient enter the clinic. And then finally, two other things. We do clinic entrance screening for some areas. So when the patient in a multi-specialty building enters that clinic and they're doing registration, if they haven't done it electronically, well, we will leverage that opportunity. The final thing that we did is very similar to the TSA pre-check. And so what we actually do is 48 hours or 24 hours before a patient has an appointment, they'll get a text. And that text, if they click on the link, will bring them to a website where they do the screen. And if they pass that screen, they will get a green badge that shows up on their phone. And if they fail the screen, they'll get a red badge and be asked to call the clinic. And that green badge is something that expires. It just disappears in 24 hours. And so that actually can bypass some of these other screens and get them right into their visit. And then finally is stage 3 of the visit, and that is the actual encounter. So first off, for COVID negative patients, we continue to follow all of the workflows and protocols that the state has mandated about social distancing. We have also worked very hard to minimize the face-to-face contact of any of our staff with our patients. We have the plastic barrier shields at our practice sites, and we also have face shields and masks, obviously, for our staff and for our providers. We think that PUIs and COVID positive patients should not be grouped together, but treated as distinctly different clinical groups. And that's because not all PUIs will have COVID. And if you mix your PUIs with your COVID patients, then every one of your PUIs that didn't have COVID will ultimately get COVID. And so we actually treat PUIs and COVIDs as two distinct and separate clinical groups of patients. We do worry about cold and flu and RSV season because the modeling that we have seen shows that surge 2.0 is going to intersect with cold, flu, and RSV season. And so we worry that we are going to have a huge number of patients who are PUIs contacting our practices. And we are working very hard to figure out how and where we're going to evaluate those patients. As I mentioned, that will bring us all the way back to step 1, where we are going to shunt most of those patients to telemedicine encounters, but we also feel we need clinical space to manage those PUIs and COVID positive patients that need to be seen. We are not planning on referring all those patients to our emergency room or our emergency department. We don't think in surge that is wise. We are worried that our EDs may become overflowing, and then we would have no options. So we are not planning to resort to that. We do plan to have separate buildings. If we don't have separate buildings, we will have separate entrances. That space will be separate, and it must have separate air handling. So those of you that are doing COVID testing in your symptomatic patients, you should make sure that the HVAC does not commingle with the HVAC of your other clinical areas, because that we think introduces risk. If you cannot do that kind of physical separation, then we recommend that you use temporal separation. So you may decide that your practice closes down at 4, and at 5 o'clock, you start seeing your PUIs on Mondays, and on Tuesdays at 5 o'clock, you see your COVID positive patients. So you must keep those patients separated from your COVID negative patients. Next slide. I'm going to finish up my presentation before we turn this over to questions by telling you our aspirational goals. And this was through our system, this is what we are working very hard to do with all our different clinical departments and all of the many practices that account for those 4 million visits that we saw last year. So as I already mentioned, we want you to leverage our practices, to leverage their EMRs using the patient portal to communicate with patients as often as appropriate, to screen them, to register and check them in, screen them in that process, and then complete the checkout tasks electronically as best you can. We also are working to make registration and our check-in process, as well as our checkout process, touchless. The less there is high contact surfaces that are infectious, the better. And so we are making everything as touchless as we can. Next slide. One of my goals well before the pandemic was to eliminate wait times. Wait times is our chief dissatisfier in our ambulatory areas, and if I could wave a magic wand and make wait times go away, that was my #1 goal pre-pandemic. Interesting to see how easy it is and how receptive practices are now to eliminating wait times and the need for waiting areas. And so, although we will not be perfect in this area, and we do have waiting areas, we have re-engineered our workflows and our patient throughput to essentially eliminate wait times and the need for waiting areas in many of our clinical spaces. That leads us to what our providers like to do, and they love to overbook. They love to overbook, and they have this temporal optimism. And we are working very hard to remind people that you need to build your templates that match the actual workflows of the visit and the cycle time of the visit. We think overbooking is a thing of the past in our practices, and you must have a defined cycle time for your patients, and your workflow and throughput should match that cycle time. Next slide, my final slide. The thing that you can do if you need a long cycle time for the throughput of your patients for in-person visits is to consider alternating telemedicine visits with in-person visits so that you are allowed to temporally space your in-person visits and not crowd your waiting room. And we are doing that in many of our practice areas, and some providers really love it. Some providers don't like it at all. They want to be either all in for in-person, or they want to be all in for telemedicine. They don't like flipping back and forth. And then finally, as you may find the need to expand space because you are slowing down your workflows and seeing patients spread out over greater time, the cheapest way to expand space is to expand your hours. And that is what we're doing in some of our practice areas as well. And with that, that is the end of my presentation, and I think we turn it over to questions.
And thank you so much, Dr. Sisson. That was wonderful insight into COVID-19 and ambulatory care within the practice. Thank you so much. So thank you to all of our presenters today. We will now begin our Q&A forum with the first question from the chat box. So Dr. Okeke, we will start with you. The first question states, it is currently taking 7 to 10 days for results. How are we going to effectively manage patients or their contacts when it is taking this long?
Thank you. That is a troubling question, but a relevant question at the same time. And that was why we had this slide up that showed the percent of COVID-19 test results that are reporting under 2 days by labs. So that way, at least you are informed. I would say this, that Quest, as you know, as an example, is a national laboratory. And with the surges in more than 14 states now across the country, demand has pooled maybe resources. That's one guess. So keep those things in mind as well, that could be one of the reasons why you're seeing a longer turnaround time. But also remember that you have labs that are giving you the same quick turnaround time that you expect. So please stay up to date with that information, and if there's a way that we can discuss with the PMO office, ways that folks can have practices can have a link to that dashboard so that they can see this in real time to kind of gauge where to send their labs to or who to partner with, that I'm sure will be very helpful. So There are labs that are, that do have a quick turnaround time. So please bear in mind that they're there and you should use them. And for those who have a longer turnaround time, they're trying, and things keep changing. Not fast enough, but they do keep changing.
Thank you so much, Dr. OKK. So the next question is for Dr. Feldman. If contact tracing involves a healthcare worker, is the healthcare worker required to stay home from work if asymptomatic? Assume proper PPE always in the office setting.
Right, so thank you for that question, and one I should have included a slide on, knowing this audience. So you are right, the healthcare worker, if asymptomatic and exposed, is not required to quarantine as members of the general public are.
All right, awesome. Thank you, Dr. Feldman.
Sure
We have another question for Dr. OKK. Any guidance for testing asymptomatic employees in healthcare settings?
Sorry, I'm muting myself. So yes, I mean, if it depends on where you work, right? So it's a broad term to say healthcare workers, but if you are a staff in your practice, nothing stops you if your practice does provide testing that you do test there, or you can go to any of the testing sites. Again, you don't need an excuse to go and get tested. You don't need to have any co-pays as well, and you can get tested regardless of your insurance status. So as much as you feel the need to get tested, reach out to your PCP to order a test for you, or you can go ahead and get tested as well.
Awesome. Thank you, Dr. OKK. And it looks like we have one more question for Dr. Feldman. Where are contact tracers sending people to get tested? Self-scheduled sites or PCP offices?
So they'll work with they'll recommend the testing, and it's a combination. If the individual has a primary care provider and insurance, then that might be a source. We post at the Maryland Department of Health all of the testing sites each week, and so that list is available to the interviewers to make available to the people they interview, so that they can direct them to the public testing sites as well.
Okay, thank you so much.
Dr. Feldman, I just want to ask a follow-up question to you, and also for the audience to hear. Have you experienced any response bias with all the contact tracers reaching out to folks? And if so, what are you guys doing to see if that can be reduced or mitigated?
Can you describe a little bit more about what you mean by the response bias? Do you mean different populations respond differently, or?
Exactly, or if you're sure that the report you're getting is accurate, right? So if I feel uncomfortable, like, what are the strategies you're using to control for that? Yes.
Right. No, it's tricky. It's very tricky, and so we haven't been able to dive deep into that yet. Anecdotally, we hear from some of the interviewers that people have been very forthcoming. They've been very appreciative of the calls, but of course we also have the ones on the other end of the spectrum where they don't want to share the information. They're a little cagey. So we haven't been able to go and validate things yet. As you're describing, we would certainly like to be able to do that. But it's always, there's always a challenge. And so this is why I think, the local health departments are so skilled at doing this, because this is what they do on a regular basis. And the NORC interviewers, one of the things we haven't been able to tease apart yet is success of NORC versus local health departments. And we're working on looking at that. But, the local health departments have this particular skill set in navigating these kinds of conversations and working with their communities, whereas many of the NORC interviewers are newer to it. Not that they're not skilled, they're all extremely well qualified, but they might not have that skill set as developed yet. But what you're describing, being able to validate the responses we get, we haven't been able to do, and we would certainly like to do.
Thank you.
So I was just going to do one more question that we have here. Can pediatric patients be tested at all testing sites? I think this might be for Dr.
Okay, I can take that.
Thank you.
Yes, they can. And also, I know that the focus of this webinar for the most part was about office testing as well. But just keep in mind that regardless of where you go to test, just be sure, depending on the age of the child, that you do have an adult there to help, especially with infant and toddlers. And there are different, you know, ways you can help to position the child for them to get the swab collected. And it's not a very comfortable process. So, but whoever is testing would be, you know, savvy enough and trained enough to let you know what to expect. So even kids can also be tested, be it an office-based testing or at the testing site as well.
All right, thank you so much. I think that actually concludes all of our questions. And I just wanted to thank all of you for your attendance. We encourage you to please complete the post survey following this training. And also please remember to apply for your CME credits if interested. Dr. Okeke will give our closing remarks. So Dr. Okeke, I'll hand it over to you.
Thank you, Ashley. So thank you everyone for being here today, and thank you for hosting Ashley, Dr. Haft, all those behind the scene you don't see here, the PMO team, Chad, Tammy, Robert, trying to remember all of you, Alice, for really putting this together and all, and making sure you guys have the guide that you downloaded to use as a resource as you think through this. Thank you, Dr. Feldman, Dr. Sisson, for being here as well. And thank you to you, our audience, and our dear primary care heroes for your dedication and all you do every day to save lives. If you can test safely in your practice, please do. But if you can't, that's fine. Please place the order for the patient to get tested. The more testing we do, the more we can begin to address this pandemic. And please stay safe and practice safe practices. Wear a face mask, wash your hands, and continue with physical distancing. Thank you all, and have a great day.